Hello everyone, in this video we are going to discuss about the appendicitis. This video is made by the Nandini group K1. This is the PPT file. You can get this PDF on the internet. Actually, appendicitis means the inflammation of the vermiform appendix. Vermiform appendix is nothing but the organs, vestigial organs of body. It stores the limbs, so it is called the lymphatic organs also, and it helps in the productions of the B lymphocytes. So before studying about the appendicitis, let's us discuss about the appendix. Appendix full name is vermiform appendix. It is located on the right iliac fossa, just below the ileocecal junctions. It is a blind muscular tube with the mucosal, submucosal, muscular and the serosal layer. At birth, appendix is short and broad at its junctions with the cecum, but differential growth of the cecum, typical tubular structure by about the age of the 2 years. During childhood, the continued growth of the cecum commonly rotates the appendix into the retrocecal, but it becomes intraperitoneal in positions. Position of the base of the appendix is constant, being found at the confluence of the three tenia coli of the cecum, which fuses of the to form an outer longitudinal muscle coat of the appendix. Various positions of the appendix. There are various positions of the appendix. Among them, retrocecal position is the greatest found among the more individuals. It is found in almost 74% of the individual. Mesentery of the appendix is also called mesoappendix. It arises from the lower surface of the mesentery of the terminal ileum and is itself subject to the great variations. And about the artery supply or vascularizations, it is supplied by the appendicular artery. It is the branch of the lower division of the ileocolic artery which passes behind the terminal ileum to enter the mesoappendix, a short distance from the base of the appendix. Now let's discuss about the appendicitis. Appendicitis means the inflammation of the vermiform appendix. Etiology: no unifying appendicitis is done. Decreases the dietary fibers and increased consumptions of the refined carbohydrates. Obstructions of the appendix lumen. Fecolith, composed of the inspirated fecal material, calcium, phosphorus, bacteria, epithelial debris, rarely of organ body. Tumor, carcinoma of the cecum. Intestinal parasites like Oxyvius, Enterobius, Vermicularis, pinform, etc. Now let's discuss about the pathophysiology of the appendicitis. The risk factors for the perforations of the appendix are the extremes of the age, immunosuppression, diabetic mellitus, fecolith, obstructions, pelvic appendix, and previous abdominal surgery. The clinical manifestations: the symptoms are the periumbilical colic, pain shapes to the right iliac fossa, anorexia, nausea. The signs are the pyrexia from 37.2 to 37.7 degrees Celsius, localized tenderness in the right iliac fossa, muscle guarding, and rebound tenderness. The signs to elicit are the pointing signs, Robinson signs, Schwarz sign, and obturator signs. In this figure, we can see the McBurney's point and obturator signs, Schwarz signs. All things can be seen here. For the differential diagnosis, it is different for children, adult female, and the adult. This is not so important. The investigations, the routinely investigation that should be done before the operations are the full blood count, urine analysis, pregnancy test, urea and electrolytes, supine abdominal radiograph, ultrasound of the abdomen and pelvis, contrast in CT scans of the abdomen. Diagnostic scoring. Diagnostic is essentially clinical. However, a decision to operate based on the clinical suspension only can lead to the removal of the normal appendix. The number of the clinical and laboratory based scoring systems have been revised to assist diagnosis. The most widely used is the Albardo score, and you can see the CT scans of enlarged appendix on the first and the appendical wall thickening in the second. In the third, you can see appendicolith, and in the fourth, you can see periappendiceal fat starting. And treatment is obviously intravenous fluids to establish the adequate urine output. Appropriate antibiotics reduces the incidence of the post-operative wound infections. When the peritonitis is suspected, the therapeutic intravenous antibiotics to cover gram-negative bacilli as well as anaerobic cocci should be given. Salicylates and appendectomy. Obviously, appendectomy is of three types: conventional appendectomy and the laparoscopic appendectomy, and we have to discuss about the post-operative complication as well. Conventional appendectomy is done in the two positions. It's done by two incisions. One is called gridiron incisions and another is called lance incisions. Gridiron incisions is done in the McBurney's line, like the right angles to the line joining the anterior superior iliac spine to the umbilicus, centered on the McBurney's point. And lance incision is done in the 2 cm below the umbilicus, centered on the mid-clavicular and mid-inguinal line. Conventional appendectomy, first cecum is identified, and base of the mesoappendix is clamped in the artery forceps, divided and ligated. The free appendix is crossed near its junctions with the cecum in the artery forceps, which is removed and applied just distal to the crossed positions. The absorbable ligature tied around the crossed positions close to the cecum. The appendix is appullated between the artery forceps and the ligature. The absorbed pores, string or jet suture may then be inserted into the cecum about 1.25 cm from the base. The strom of the appendix is invaginated while the pores, string or jet suture is tight, thus boring the appendix strom. Here you can see in 1, 2, 3, 4 figures how appendectomy is performed. And let's discuss about the laparoscopic appendectomy. The placement of the operating ports may vary according to the operator's preference and the previous abdominal scars. The operator stands to the patient's left and faces and the video monitor placed at the patient's right foot. The moderator Trendelenburg tilt to the operating tables. The appendix is identified and controlled using the laparoscopic tissue holding forceps. By elevating the appendix, the mesoappendix is displaced. The dissecting forceps is used to create a window of the mesoappendix to allow the appendicular vessels to the coagulate or ligated using a clip applicator. The appendix, free of its mesentery, can be ligated at its base with an absorbable loop ligature, divided and removed through one of the operating parts. It is not usual to invert the strom of the appendix. A single absorbable suture is used to close the linea alba at the umbilicus, and the small skin incisors may be closed with the subcuticular sutures. Patients who undergo laparoscopic appendectomy are likely to have less post-operative pain and to be discharged from the hospital and return to activities of the daily living sooner than those who have undergoes an open appendectomy or conventional appendectomy. Here we can see the figures of the how surgical incision is done in the lance incision. It is lance incisions, and laparoscopic incisions. There are 4 holes are made, and this is the figures of the laparoscopic operations surgery. And what are the problems encountered during the appendectomy? The problems are the normal appendix is found, and appendix cannot be found, appendicular tumors is found, and appendix abscess is found. When the normal appendix is found, then the demands careful exclusions of the other possible diagnosis. Remove the appendix to avoid the future diagnostic difficulties. If the appendix cannot be found, then cecum should be mobilized and the taenia coli should be traced to the confluence on the cecum behind the diagnosis of the absent appendix is made. Then if the appendicular tumor is found, then small tumors less than 2 cm in diameter can be removed by the appendectomy. Larger tumors will be treated with the right hemicolectomy. An appendix abscess is found and the appendix cannot be removed easily, then should be treated by the local peritoneal toilet, drainage by the abscesses and the intravenous antibiotics. And appendix mass. If the appendix mass is present and the condition of the patient is satisfactory, the standard treatment is the conservative. Careful recording of the patient's conditions and the extent of the mass should be made, and the abdomen regularly re-examined. Temperature and pulse should be recorded 4 hourly, and the fluid balance record maintained. A constant in CT examinations of the abdomen should be performed and antibiotic therapies instigated. And abscesses, if present, should be drained radiologically. Clinical deteriorations or evidence peritonitis is an indication for early laparotomy. Clinical improvement is usually evident within 24 to 48 hours. And criteria for the established conservative treatment of the appendix mass are the rising in the pulse rate, increasing or spreading abdominal pain, increasing size of the mass. And what are the post-operative complications? The post-operative complications are the wound infections, intra-abdominal abscesses, adhesive intestinal obstructions, and there may occur the ileus in respiratory pneumonitis or collapse, venous thrombosis and embolisms, portal paema, and fecal fistula. Now, other causes of the acute appendicitis are the recurrent acute appendicitis and neoplasm of the appendix. Recurrent acute appendicitis is widely known but unfavorable. Not uncommon for the patient to attribute such attacks to biliousness or dyspepsia. Attacks vary in intensity and may occur every few months. Through history, patients might have had milder but smaller attacks of pain showing fibrotic appendix indicative of the previous inflammations. Chronic appendicitis does not exist, however, there is evidence of the altered neuroimmune functions in the meningeal nerves of the patients with so-called recurrent appendicitis. And this is the excised appendicitis of the point luminal obstructions with the distal fibrosis. And neoplasm of the appendix suggests the carcinoid tumor and the primary adenocarcinoma. Okay, thank you for watching this video. Enjoy your time. Thank you.